Hey there! My name is Abby, the dialysis guy, and today we're diving deep into the world of ECMO. I know what you're thinking. What is ECMO, and why is it such a big deal? Well, by the end of this video, you'll not only know what ECMO is, but also how it works, the different types, and the nitty-gritty details that can save lives in the ICU. Stick around till the end, because trust me, this is going to be a ride full of fascinating info that might just blow your mind. Alright, let's start with a bit of history to give you some context. ECMO, or extracorporeal membrane oxygenation, actually comes from the technology used in cardiopulmonary bypass systems. These were first developed and used in open-heart surgeries in the 1950s. Now, fast forward to 1972, Dr. Robert Bartlett performed the first successful ECMO procedure on an adult patient. This was a game-changer. Over the years, ECMO's design, anticoagulation methods, and patient management have improved dramatically, turning it into the life-saving technology we rely on in ICUs worldwide today. First, veno-arterial ECMO. This one provides both cardiac and respiratory support. How does it work? Blood is drained from a large vein, like the femoral or internal jugular vein, and pumped back into a large artery like the femoral artery. This is used for patients in cardiogenic shock, after cardiac arrest, or those with severe heart failure. On the other hand, we have veno-venous ECMO. This one focuses solely on providing respiratory support. Blood is drained from a vein and returned to another vein, like femoral to internal jugular vein. This is the go-to for ARDS, pneumonia, or lung failure patients. So, when exactly do we turn to ECMO? Let's break down the indications for both veno-arterial and veno-venous ECMO. For veno-arterial ECMO, it's mostly used in situations where the heart needs a little help, like in cardiogenic shock, after a myocardial infarction, or in severe myocarditis. It's also crucial in refractory cardiac arrest. We call this ECPR, or extracorporeal cardiopulmonary resuscitation, and post-cardiotomy heart failure. Oh, and don't forget, massive pulmonary embolism with hemodynamic instability. As for veno-venous ECMO, this one's for the lungs. It's used for severe ARDS, think COVID-19 pneumonia, refractory hypoxemia despite mechanical ventilation, or lung trauma from things like aspiration or toxic inhalation. It can also be a bridge to a lung transplant. Now, ECMO isn't for everyone. There are some strict contraindications to be aware of. We have absolute contraindications, like irreversible multi-organ failure, severe brain injury, for example, brain death, or if a patient has end-stage terminal illness with no recovery potential. These are pretty clear red flags. And then there are relative contraindications like advanced age, though this depends on the institution's guidelines, uncontrolled bleeding, severe coagulopathy, or if the patient's on high-dose vasopressors for an extended period, which usually suggests a poor prognosis on veno-arterial ECMO. For ECMO to work, we need to get the blood flowing. That's where vascular access comes in. For veno-venous ECMO, we have a few options. One popular method is using a dual-lumen cannula. This is a single-site access where blood is drained from both the superior and inferior vena cava and returned to the right atrium. Or, for patients needing higher flow support, we can use a dual cannula approach, where one cannula drains blood from the femoral vein and the other returns it to the internal jugular vein. As for veno-arterial ECMO, the options are a bit more complex. You've got peripheral veno-arterial ECMO, which can be done at the bedside by inserting cannulas into the femoral vein and femoral artery. But there's also central veno-arterial ECMO, which requires a surgical approach with cannulas placed directly into the right atrium and ascending aorta. Let's talk numbers now. ECMO prescriptions and settings. These are crucial to getting ECMO right. The blood flow rate for veno-arterial ECMO usually sits between 3 to 5 liters per minute, and for veno-venous ECMO, you're looking at about 2.5 to 4.5 liters per minute. The goal is to optimize oxygenation and perfusion. Next up is sweep gas flow. This one controls carbon dioxide removal from the body. More flow means more carbon dioxide removal. It's like adjusting the ventilation on a car engine. And for the FiO2, or the fraction of inspired oxygen, we typically start with 100% oxygen and gradually reduce it to prevent oxygen toxicity. Don't forget about anticoagulation management. We generally use heparin to target an activated clotting time, ACT, of 180 to 220 seconds, or an activated partial thromboplastin time, APTT, of 40 to 60 seconds, to keep things flowing smoothly. Now, ECMO is an incredible tool, but it comes with risks. Let's look at some of the common complications. First up, bleeding, from cannulation sites, intracranial hemorrhage, or even gastrointestinal bleeding. Then we have the thrombotic risks, like circuit clotting or stroke. Mechanical failures can happen too, like pump malfunction or oxygenator failure. Another serious risk is limb ischemia, especially with veno-arterial ECMO, where poor perfusion to the limb can occur. And, as with any invasive procedure, infection is always a concern, especially when ECMO is used for long periods. Nurses play a vital role in managing ECMO. You've got to keep a close eye on hemodynamics and oxygenation. Check for clots, air bubbles, or kinks in the circuit, and monitor neurological status, especially for signs of stroke or intracranial hemorrhage. And don't forget to check limb perfusion in veno-arterial ECMO patients. Keeping the leg where the cannulas are inserted in good shape is essential for preventing complications. Let's get a little more advanced with Harlequin syndrome or differential hypoxia, which can occur in veno-arterial ECMO. It happens when oxygenated blood from ECMO meets poorly oxygenated blood from a failing heart. This can lead to the upper body being under-oxygenated while the lower body is well oxygenated. Managing this involves optimizing ventilation, FiO2, and if needed, switching to central veno-arterial ECMO to improve oxygenation. Finally, weaning off ECMO. For veno-venous ECMO, we look for stable oxygenation with FiO2 less than 40%, decreased sweep flow, and stable hemodynamics. For veno-arterial ECMO, we assess left ventricular function, decrease blood flow, and ensure stable hemodynamics off vasopressors. Phew, that was a lot, wasn't it? But ECMO is truly a life-saving therapy, and understanding it fully can make a massive difference in patient outcomes. I hope you found this breakdown helpful. Thank you for watching. This is Abby, signing out. See you soon with a new video where we'll simplify more complex healthcare concepts just for you. Stay tuned and take care.